the prostate histology, the common diseases, and the treatment. So, coming to the normal prostate anatomy, you know it has multiple lobes, one medial lobe, anterior, posterior, one capsule, venous plexus within the capsule, and in the middle, just behind the medial lobe, there is a passage for urethra, male urethra, prostatic part of urethra. So, what is the most commonly encountered disease in prostate that we generally found in our clinical practice? That is the nodular prostatic hyperplasia or benign hyperplasia of prostate or BHP in short. So, as we can guess it from the name, that nodular hyperplasia of prostate, the gross picture or the macroscopical appearance of the involved organ takes a shape of multiple nodules. So, it is named as nodular prostatic hyperplasia. This is, you can see the multiple nodules. These are all the hyperplasia of glandular and stromal components, and there is compression of the urethra and false capsule formed by the compressed glandular tissue. Okay, and as the nodules, the hyperplastic nodules, they tend to compress the urethra, the patient will have many obstructive uropathy symptoms like incontinence or hesitancy, urgency, and decreased flow of urine, etc. Now, carcinoma of prostate, that is a different entity, will be taught later. Mainly in the peripheral part, it occurs the peripheral lobe and it occurs away from the urethral orifice. Paraurethral glands are mostly spared. Now, coming to the introduction, what is a prostatitis? As we know it from the name, that it is inflammation of the prostate tissue, whether it is acute or chronic or granular metastatic. So, microscopic inflammation of the tissue of the prostate gland, and is a diagnosis that spans a broad range of clinical conditions. So, inflammation of the prostate, it can be acute, it can be chronic, and it can be granulomatous types. And the most common organisms causing the inflammation of prostate are mostly gram negative, and up to 75 to 80% prostatitis cases are caused by E. coli species. Next, Klebsiella, Protea, Pseudomonas, Enterobacter, Gonococci, and very less amount of cases are caused by Staphylococci. But gram negative organisms, mostly E. coli, is chief responsible pathogen to cause acute prostatitis. Now, what is the cause of chronic prostatitis? A primary voiding dysfunction problem, either structural or functional. So, voiding dysfunction problem is mainly the lack of micturition ability of the elder male or the male who has crossed the fourth decade of his life, more than 40 years. He has his testosterone activity, dihydrotestosterone activity, and active sexual life. Then he will get the symptoms of chronic prostatitis due to dysfunctional voiding problem, or the urine that has the normal blood flow of urine that is reduced by time due to hyperplasia of prostate, and the decreased flow of the urine cause the accumulation of the urine as well as the retrograde going up of the urine flow and cause infection subsequently. So, voiding dysfunction problem, either structural or functional. E. coli responsible for 75 to 80% of chronic bacterial prostatitis cases, as I told you earlier. And the organisms are Enterococci, Pseudomonas, Chlamydia trachomatis, Ureaplasma species, and uncommon organisms are tuberculosis, histoplasma, and candida species. Excuse me. Most common organisms are E. coli, then Pseudomonas, Enterococci, Chlamydia trachomatis, Ureaplasma, Urealyticum, and the less common organisms are Mycobacterium tuberculosis, histoplasma, candida species. These rare organisms mainly cause prostatitis in case of immunocompromised individuals. So, tuberculosis prostatitis may be found in patients with renal tuberculosis, human immunodeficiency virus or HIV infection, cytomegalovirus, and inflammatory conditions like sarcoidosis. So, if there is chronic inflammatory condition, if there is breach in the immunity, if the patient is having immunocompromised state, then their prostate may be vulnerable to be infected by less common organisms like Mycobacterium tuberculosis, Candida, and cytomegalovirus. Now, epidemiology, I have told you after 4th decade, the symptoms may arise. Non-bacterial prostatitis type 2 and type 4 are most common among older patients. According to the case reports of Wegener granulomatosis in the 4th and 5th decades of life, prostatitis can be a presenting feature of Wegener granulomatosis and clinical relapse. So what is Wegener granulomatosis? It's an autoimmune disease and it mainly involves the medium-sized blood vessels due to autoimmune destruction of the vessel wall and subsequent narrowing of the vessel. So, in a spectrum of Wegener granulomatosis, prostatitis may happen as the initial symptoms. Fungal infection with Candida albicans and mycobacterial infection with Mycobacterium tuberculosis have also been reported. Now, there are 4 types of prostatitis. 4 types of prostatitis according to a classification that is postulated in 1999 probably. So, classification, according to the classification, there are 4 types of prostatitis: type 1, type 2, type 3 and type 4. Type 1 is acute bacterial prostatitis, type 2 is chronic bacterial prostatitis, type 3 is chronic pelvic pain syndrome, and type 4 is asymptomatic inflammatory prostatitis. So, type 3 chronic prostatitis and chronic pelvic pain syndrome further classified as inflammatory and non-inflammatory. So, if the culture is positive from the prostatic secretion, then it's called as inflammatory, and if culture is negative from the prostatic secretion, then we can say it as non-inflammatory. So, to the basics, the classification of prostatitis is mainly composed of 4 categories: type 1, type 2, type 3 and type 4. Type 1 is acute prostatitis, type 2 is chronic prostatitis, type 3 is chronic prostatitis as well as chronic pelvic pain syndrome and granulomatous prostatitis as well, and type 4 is asymptomatic inflammatory prostatitis. So, patient won't have any symptoms of pain, patient won't have any symptom of fever or obstructive uropathy like symptoms, but the prostatic secretions may have the etiologic agent when we done the secretion in proper culture media. So, acute prostatitis and chronic bacterial prostatitis are defined by the documented bacterial infection. So, you have to document the bacterial infection from the culture. So, in culture, for the favoring the gram-negative organism growth, we can find E. coli, we can find Pseudomonas, we can find Enterobacter, we can find gonorrhea, and treated with antibiotic therapy according to the sensitivity report and supportive therapy as well. So, in pathophysiology, coming to the pathophysiology, what is the pathophysiology? In bacterial prostatitis, sexual transmission of bacteria is very common. So, the contamination with the secretion that is involves in close intimate relationship. So, acute bacterial prostatitis, sexual transmission of bacteria is common, but hematogenous and lymphatic spread also have been documented. Hematogenous and lymphatic spread from the local adjacent organs like rectum, local adjacent organ like urethra. So if any infection, any insult, any bacterial colonization happens in rectum and in urethra, so there will be a fair chance that his prostate will be involved by the same bacteria as well, and patient will feature as a symptoms of bacterial prostatitis. Contagious spread of infection from surrounding organs like urethra and rectum. Although various routes have been postulated, none has been firmly substantiated. A history of sexually transmitted disease is associated with an increased risk of prostatitis symptoms. So, sexually transmitted diseases like syphilis, like gonorrhea, are also has been associated with the incidence of prostatitis. Now, viral and granulomatous prostatitis is also common, and it is common in the patient of immunocompromised individuals. Okay, like HIV infected, a very common viral pathogen is cytomegalovirus. Cytomegalovirus, we can see in MCQ paper, MCQ questions, that cytomegalovirus infection, it causes a nuclear inclusion. So cytomegalovirus is very common in immunocompromised patient or immunosuppressed patient, and it is characterized by the nuclear inclusion by the virus. Mycobacteria such as Mycobacterium tuberculosis and fungi as Candida albicans have also been associated with culture negative disease in population. So, in our normal routine culture, we culture for the gram-negative bacteria like E. coli, like Pseudomonas, like Enterobacter, but in common culture mechanisms, we don't culture for the organisms that are rare. Those are rare, like Candida or fungal culture is not very common. Viral culture is not very common. So, culture negative prostatitis, if any patient we can get culture negative prostatitis, then you should test the acute prostatitis. Acute bacterial prostatitis may be caused by ascending infection. That I told you that dysfunctional voiding, either structural or functional. So, the regurgitation of the urine, reflux of the urine occurs from the membranous part of urethra to the prostatic part of urethra, and the prostate may be involved by the notorious pathogens or gram-negative bacteria, and the reflux finally contaminates into the ducts and symptoms of prostatitis occurs, or direct extension or lymphatic spread from the rectum, as we told earlier. Now, acute prostatitis may occur spontaneously or may be a complication of urethral manipulation. So, the organism may be inoculated from the outside by the iatrogenic procedure. Iatrogenic procedure means the procedure that has been developed by the doctor or the technicians. So, if any patient, we done the cystoscopy, but we don't maintain the proper sterile atmosphere or sterile environment before the procedure, so there is a high chance that after cystoscopy, patient will develop the symptoms and features of prostatitis. So, intraurethral catheterization, cystoscopy, urethral dilatation, surgical procedure on prostate. These are medical or surgical intervention. Those are responsible for prostatitis if proper sterile environment or sterile atmosphere has not been maintained enough. So, common pathogens which cause UTI most frequently: E. coli, same chart, E. coli, Klebsiella, Proteus species, Pseudomonas, Enterobacter, Gonococci, Staphylococcus. But the bacteriological diagnosis or the etiological diagnosis is made confirmed by the culture. So, what are the morphological features of prostatitis? A patient of acute prostatitis may not come to you for excision of his prostate. So it is very hard to find the prostate as our specimen if the patient has been treated with antibiotic or the patient has been treated with for infective etiologies. So acute bacterial prostatitis, chronic bacterial prostatitis, these are very easy to treat nowadays. So it is quite difficult to get a specimen of those samples or those infected specimen after surgery. But grossly we can see that the prostate is enlarged, swollen and tense due to acute inflammation like swollen or edema occurs, temperature increased, and multiple cut section, multiple abscess and foci of necrosis. So acute prostatitis, the gross feature of prostate is swollen, it is tender, and on cut section multiple abscesses and necrotic foci may be seen. And what are the microscopic feature? The prostatic acini, the ducts, they are filled with neutrophilic exudates. So the neutrophils, the most common cellular component to combat the acute inflammation, these neutrophils may be reached in exudation or exudate formation within the acini. So dilated and filled with neutrophilic exudate, there may be diffuse acute inflammatory infiltrate as well as neutrophilic exudation. Edema, hyperemia and foci of necrosis frequently accompany acute inflammatory involvement. So edema, hyperemia, this is common like any other acute inflammation we can see in prostate too. Now chronic prostatitis is more common. Why? Because of dysfunctional voiding mechanism. Why? Due to reflux of the infected urine or due to direct extension from the urethra or the surrounding rectum. So chronic prostatitis is more common and foci of chronic inflammation are frequently present of prostate of men of more than 40 years of age. Okay, and chronic prostatitis is usually asymptomatic but maybe come with other symptoms like iritis, other symptoms like arthritis, allergic reaction, etc. Okay, if any immunological mechanism occur, ওই ফোসাইটায় খুব কথা হচ্ছে, কথা বলার ফোকাস, কথা বলিস না বেশি, একটু শোন। So if the immunity or autoimmune mechanism occurred behind the cause of chronic prostatitis, other symptoms like allergic reactions, arthritis and iritis or inflammation of the iris may occur. No types of prostatitis, that is two types, chronic bacterial prostatitis and chronic abacterial prostatitis. So in chronic bacterial prostatitis we can see the bacterial growth whenever the prostatic secretion is set to culture for growth of anaerobic bacteria. But chronic abacterial prostatitis, patient will have the symptoms, patient will have the pain, patient will have the features of chronic prostatitis like lymphocytic infiltration, like pain, like UTI, but there is no bacteria, but no bacterial pathogen has been isolated from their culture. So types of chronic prostatitis is mainly of two types. One is chronic bacterial prostatitis and another is chronic abacterial prostatitis. Now coming to chronic bacterial prostatitis is caused much the same way by the same organism as acute prostatitis, but what is chronic? It occurs and it lasts in patient for more than 6 to 8 weeks. It is generally a consequence of recurrent UTI. So the male patient who have poor hygiene regarding his micturition, regarding his toilet sense, he may get recurrent UTI, and after the several attacks of urinary tract infection, repeated urinary tract infection, his prostate may be infected by the same way, and the patients will have the symptoms of chronic prostatitis. And diagnosis is made how? WBC count more to 10 to 12 per high power field in prostatic secretion. So if prostatic secretion is squeezed and is weight mounted and seen under the microscope, more than 10 to 12 WBCs are seen in per high power field. Okay. So this condition is more difficult to treat since antibiotic penetrate the prostate very poorly, as well as very poor antibiotic penetration to the prostate, as well as the poor hygiene sense and poor hygiene, toilet hygiene of the patient. So chronic bacterial prostatitis is more common. No history of recurrent UTI and urinary culture prostatic secretion always negative. But the pathogen implicated chlamydia trachomatis and urea plasma ureolyticum. So this is an important question for MCQ. Chronic bacterial prostatitis, the pathogens implicated are chlamydia trachomatis and urea plasma ureolyticum. So these chronic bacterial prostatitis patients commonly shows no growth in normal common culture medias. And what are the morphological features? The grossly prostate may be enlarged, fibrosed or shrunken. So fibrosis and shrunken, fibrosis and contraction of the size. So decrease in the volume of the prostate is mainly the hallmark of chronic prostatitis. So repeated inflammation, chronic inflammation, it increases the fibroblastic activity, it increases the myofibroblastic activity, and actually after the subsidence of the inflammation, the prostate decreases in size. So grossly, mostly prostate may be fibrosed and shrunken in size. And the microscopic feature, they are in acute prostatitis, the infiltrate chiefly composed of neutrophils or acute inflammatory cells. But in case of chronic prostatitis, the inflammatory infiltrates are composed of lymphocyte, histiocytes, plasma cells. The chronic inflammatory cells like lymphocyte, plasma cells, macrophage or histiocytes, neutrophil may be present. Prostatic calculi and foci of squamous metaplasia in prostatic acini may accompany. Okay. So prostatic calculi due to long-standing UTI infection, due to long-standing micturating problem, due to stasis of urine in prostatic urethra, calculi may occur. And metaplasia. What is metaplasia? You have written very long answer whenever asked you in your exam as short note. Metaplasia, that is change of one type of epithelium to the other, and mostly this is reversible after withdrawing the offending agent. It may go back to its original epithelium. So squamous metaplasia, normally prostate is lined by columnar epithelium or glands low cuboidal or columnar epithelium, but in case of chronic prostatitis, squamous metaplasia in prostatic acini may accompany the microscopic feature. Now, what is granulomatous prostatitis? Granulomatous prostatitis, this is a very close differential diagnosis with tuberculous prostatitis, that is extremely rare, tuberculous prostatitis. But in granulomatous prostatitis, what we can get? The granuloma forming cells like the lymphocytes, like the activated macrophage or epithelioid cells, sometimes the multinucleated giant cells. So granulomatous prostatitis is a variety of chronic prostatitis probably caused by the leakage of prostatic secretion into the tissue or could be the autoimmune origin. So the prostatic secretion in the tissue, the host tissue, they recognize the prostatic secretion as a foreign substance and they try to inhibit the foreign substance. As a result, the granuloma-like reaction occur, and coming to the scenario, lymphocytes and activated macrophage also come to the picture to combat the inflammation. So gross finding is prostate is firm to hard, giving the clinical impression of prostatic carcinoma on rectal examination. So per rectal examination or two-finger test, we can palpate the prostate, as prostate is just anterior to the rectum. So if I experience surgeon do the per rectal examination of a patient of prostatitis or granulomatous prostatitis, he or she can feel the consistency of prostate that is hard, firm to hard. and that mimics that the patient might have the prostatic carcinoma. And what is the microscopic picture? The inflammatory reaction consists of macrophages, lymphocyte, plasma cell, and some multinucleated giant cell. So the granuloma forming cells like lymphocyte, plasma cells, histiocytes, and multinucleated giant cell can be also seen in granulomatous prostatitis. This condition may be confused with tuberculous prostatitis. So tuberculosis is also a granulomatous inflammation. So the close differential diagnosis of granulomatous prostatitis is tuberculous prostatitis. So clinical presentation is acute bacterial prostatitis, very common, fever, chill, dysuria, malaise, arthalgia, myalgia, perineal and prostatic pain. Perineal and prostatic pain, the pain may be referred to the scrotum, pain may be referred to perineum, pain may be referred to the umbilicus, pain may be referred to the inguinal ligament. So there is chronic pain syndrome or the perineal region pain of a patient of long duration, more than 4 to 6 weeks. Then you have to evaluate the patient whether the patient have been infected by any bacterial in his prostate or any prostatitis is growing within the patient. Dysuria and perineal and prostatic pain, these are most common. These are all constitutional symptoms, and fever and chills are most common clinical features like symptoms, and obstructive symptoms very common, and these are the mostly the first symptoms that the patient will present to you in case of chronic bacterial prostatitis, like frequency, like urgency, dysuria, hesitancy, weak stream, incomplete voiding. So frequency, urgency, dysuria, incontinence, these are the symptoms that are most commonly encountered for the patient of chronic prostatitis, and mostly these symptoms are the first few symptoms that have been presented to the clinician by the patient. Okay. Next is low back pain, low abdominal pain, and spontaneous urethral discharge. So these are spectrum of symptoms. Some are systemic, some is local, some is constitutional, and some are the specific. But frequency, urgency, dysuria, these symptoms, if any patient comes to you, then you have to evaluate the status of the prostate of this patient. And chronic bacterial prostatitis, clinical presentation same, no systemic symptoms. Instead, this patient has urinary symptoms, intermittent dysuria, intermittent obstructive urinary tract symptoms, recurrent urinary tract infection. So intermittent dysuria and intermittent obstructive symptoms like hesitancy, urgency, incontinence, and incomplete voiding, these occurs in the patient of chronic prostatitis. Pelvic pain or discomfort, perineal, as told earlier, perineal, suprapubic, coccygeal, rectal, urethral, testicular or scrotal pain for more than 3 or previous 6 months without documented urinary tract infection from uropathogen. Ejaculatory pain, erectile dysfunction can also occur as a symptoms in the patient of chronic bacterial prostatitis. So there are spectrum of clinical features. If the question asked in your question paper, so don't forget to write the constitutional symptoms like fever with chills, pain, dysuria, and also the obstructive symptoms like incontinence, urgency, hesitancy, and incomplete voiding. Okay. So what are the complications? Complication is bladder outlet obstruction or urinary retention, abscess, typically in immunocompromised patient, infertility due to scarring of the urethra or ejaculatory duct, recurrent cystitis, pyelonephritis, renal damage, and sepsis. So what are the complications of prostatitis? Mainly bladder outlet obstruction or urinary retention due to the increased volume of the prostate, abscess in acute prostatitis, infertility due to scarring of ejaculatory duct or urethra, scarring due to complication of chronic prostatitis. recurrent cystitis, pyelonephritis, a painful syndrome for the patient, renal damage, and ultimately if the bacterial infection is overwhelming and left untreated, then sepsis will occur. And finally, diagnosis. How can we come to the diagnosis of a prostatitis? History, physical examination finding like parrectal examination, analysis of express prostatic secretion we can get. In prostatic secretion, we told earlier, more than 10 to 12 WBC in per high power field, and absence of systemic symptoms and persistence of pain for at least 3 months indicate chronic prostatitis. Okay. In addition to prostatitis, other conditions to consider including the following. So, benign prostatic hyperplasia, very important, very common. What happens in benign prostatic hyperplasia? The hyperplasia. What is the meaning of hyperplasia? Increase in number. So, the number increased of which components? Both the components, the glandular components and the stromal component or the muscular component. Prostate is a fibromuscular glandular organ. So, in hyperplasia, these three components that increases in number. The glands components are increased in number, the smooth muscle component increases in number, the fibroblastic component increases in number. So, the prostate will take a shape of multiple nodules and it increases in size and obstruct the urethra and causes obstructive symptoms. Cystitis, erectile dysfunction are also common. And what are the diagnosis modalities of the prostatitis? Urine examination, urine analysis, prostatic secretion examination, urine culture, complete blood count, blood biochemistry, blood urea nitrogen, then specific marker PSA or prostatic specific antigen. The prostatic specific antigen, that is the cutoff value, the normal range up to 4. In infection, in prostatitis, this may rise. The prostatic specific antigen, the value increases up to 10 to 12, up to 20. But in case of prostatic carcinoma, this value goes higher to many-fold, up to 100, 100, 200. So, prostatic specific antigen, this is very important marker to exclude involvement of prostate, whether it is benign due to hyperplasia of prostate or it is cancerous situation. And the imaging modality is ultrasonography, CT scan, MRI, and micturating cystourethrogram or voiding cystourethropy. So, micturating cystourethrogram, the patient is asked after taking a dye to micturate, and the graph shows the voiding volume of the urine, the initial volume, the initial pressure, the mid volume, the closing pressure, all are recorded and all are represented by a graph and interpreted by a urologist whether any obstruction or any obstructive symptoms occur in the patient can be correlated by the graphs of voiding cystourethrogram. Cystoscopy, that is a probe with a camera, is inserted within the urethra and the bladder, the inner surface of the bladder is visualized in a screen, and urine cytology studies to show whether there is any presence of leukocytes, whether any presence of urothelial cells or any malignant cells. So, these are very important for diagnosis of prostatitis: urine analysis, routine REME, urine culture, complete blood counts. It increases total leukocyte count in prostatitis, acute prostatitis cases, 15,000 to 20,000 total leukocyte count, mostly neutrophilic leukocytosis, biochemistry, and this is very important, PSA, prostate, ultrasonography, CT, MRI, these are all imaging modality. It shows the volume of prostate, the amount of residual volume of urine that the prostate will have after micturition, and voiding cystourethropy and cystoscopy finally. So urine analysis and urine culture can confirm the presence of infection and identify pathogens. So gold standard of diagnosis is culture. Gold standard, if somebody asks you the gold standard of diagnosis of prostatitis, you say culture and sensitivity. So until and unless you demonstrate a growth in growth of any bacteria in prostatic secretion, you cannot confirm to tell that the patient is having a bacterial prostatitis. Fractional urine study, cytology of the prostatic secretion can help differentiate prostatitis from urethritis and cystitis. So, now the interesting part, this is, you can see the nodules, multiple nodules. So this is a gross picture of benign hyperplasia of prostate or nodular hyperplasia of prostate. As the name suggests, we can see there are multiple nodules and it compresses the capsule and the urethra. So this is a nodular hyperplasia of prostate, the prostatectomy specimen, the whole prostate. This kind of operation is obsolete nowadays. This is a specimen we can get from radical prostatectomy. The prostate as well as the including the capsule has been enucleated. But now what is the main surgical procedure for benign hyperplasia of prostate? That is TURP, transurethral resection of prostate. So in TURP there are small bits of prostate. We can get a specimen, but this is the specimen that come from radical prostatectomy. So this we can see this is increase or hyperplasia of the stromal fragment and the glandular parts. So multiple nodule that compress the main prostatic tissue and urethra as well. So this is the whole mount view of prostate in benign hyperplasia of prostate. The increase in number of glands and increase in number of stromal elements. These are the glands. Whole mount view. Whole mount means the entire specimen is processed and mounted in a slide. So this is whole mount view and this is low power view. We can see this is dilated acini. Everybody can see these pictures. Dilated acini and the hyperplasia of the stromal fragments or the smooth muscle cells or fibrous element in between. This is gland, these are gland, the whitish glands with the secretion in between. This is gland. And these are the hyperplasia of the stromal fragments or smooth muscle or fibrous component. This is the low power view in scanner. Now this is the high power view. We can see these are gland lined by columnar epithelium filled with secretion, prostatic secretion, and these are cystically dilated. Okay, and the intervening stroma, these are also hyperplastic or increase in number. These are stroma, this is stroma, this is stroma, in between this is stroma, but these are gland. And glands are mostly closely facing each other with their sharing a common margin. Sharing a common margin, these two glands, and cystically dilated. Okay, filled with secretion. So this is the histopathology picture of high power view of benign hyperplasia of prostate. Now, low power view of acute prostatitis. You see many neutrophils in between. These are gland acini. This is also acini. You can see in acini, what we told you that neutrophil rich exudate. This is neutrophil. 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 So neutrophil rich exudate in acini as well as stroma. This is neutrophil. You can see. এই কথা বলছিস কেন? কি ছবিটা দেখতে দেখতে কথা বলছিস? আচ্ছা কি বলছিস? ওকে, কথা বলিস না, শোন। These are neutrophils. Okay, so this is a case of acute prostatitis. The acini are filled with neutrophilic exudates and hemorrhage, and these are all acute inflammatory cells, mostly neutrophil in stroma as well as in gland. Now, in high power view, these are all neutrophils, inflammatory exudates. This is gland, but gland is loaded with neutrophils. This is neutrophils. In acini, neutrophils. These are neutrophils. Multiple punctate neutrophil, multiple. Extensive neutrophilic infiltration. Everybody can see? And finally, this is a picture of chronic prostatitis, mostly the lymphocyte and histiocyte. This is lymphocyte. Okay, this is glands, this is lymphocyte, few histiocytes. So, this is high-powered view of chronic prostatitis, and this is infiltration of chronic inflammatory cells like lymphocyte, plasma cell, and histiocytes. Lymphocytes are most common and more common inflammatory infiltrate in case of chronic prostatitis. So, thank you everybody. Attendance.